Oh, sorry, that's why I was figuring. Wonderful.
All purple? Dr. Mathee. Surprise, surprise.
I didn't do that.
Okay.
All right, good afternoon, Dr. Chan. I hope you're doing well. My name is Jasmine Lakhtar Aziz. We are the Garnets, and this is our case presentation. So we had a 12-year-old male who was brought with his parents to the emergency department in northern India. His parents informed us for the last 5 days, he had a fever that ranged from low-grade intermittent to high-grade continuous. In the last 3 days, he had a productive cough with phlegm that was yellow, non-foul smelling, and non-blood stained. The last 2 days, he had painful swallowing, both liquids and solids. He also had difficulty breathing and a slightly hoarse voice. His breathings were labored and noisy, and according to his mother, his vaccination status is not up to date for his age.
Hello, Dr. Chan. My name is Ogena TK, and upon examination, he had a temperature of 102 degrees Fahrenheit. His heart rate was 120 beats per minute. His respiratory rate was 24 breaths per minute. He had the presence of an inspiratory stridor. There was no abnormalities detected during his systemic examination, and he was conscious and oriented but looked toxic. Based on this information, do you have any ideas?
Wow. The 12-year-old kid apparently is very, very sick. I assume he was a healthy child before this. And again, it's very important to know the prior vaccination record, especially in northern India. But let's assume he got all his childhood immunization. And his presentation is relatively acute, only a few days, and mainly really having difficulty breathing, cough, and a sputum production. So that suggests a pneumonia. But on top of it, he also had dysphagia. He had difficulty swallowing. So that's a bit unusual. So I assume this only happened in the oral pharynx and nothing to do with, let's say, his esophagus or, further down. That means he might have a extremely painful and red, swollen, throat. So what I would do by exam, I would definitely try to feel his lymph nodes, especially those in the neck, the cervical area, the submandibular area. And I would definitely take a good look in his throat to see whether he has any peritonsillar abscess. Now in India, you really had to look for even diphtheria. I only saw one case of diphtheria in my entire life, and that was like 40 years ago. The so-called gray membrane, Now usually children with diphtheria had a very toxic cardiotoxicity. So not just looking toxic, they also have a lot of rhythm issue, congestive heart failure, and so forth. So I would definitely look at all that, and obviously take a chest x-ray, listen, and the throat culture will be most important. And when in doubt, maybe get ENT to take a good look, or take a CAT scan of the neck, head and neck area and see what's happening. I'm going to stop here for the time being. Thank God he didn't have meningitis because his mental status is good. Oh, here we go.
An oropharyngeal examination was done on him. He had grayish-white membranous patches on his tonsils. They were hypertrophied. His soft palate was congested with poor orodental hygiene. His uvula, soft palate, anterior pillar, and posterior pharyngeal wall was congested and edematous. Posterior pillar was not visible. Based on this new information, do you have any ideas?
Well, I can't say. One can make a diagnosis strictly by looking. In the old days when the illness is very prevalent, then clinicians tend to make it that, oh, this is a diphtheria, But now you really should do, culture or PCR and also definitely had to send a strep antigen. Nothing to say it's not a strep throat either, or even any of the other severe bacterial pharyngitis. And the other thing we want to look at is whether his epiglottis is swollen or not. You have a swollen epiglottis, that may imply Haemophilus epiglottitis, and that could be a acute emergency. He may just asphyxiate. He already has stridor. So the decision right now is whether this child should have an immediate tracheostomy to bypass, and you can control the airway. So otherwise he will suffocate. I don't know what this yellow sputum was. It truly from the lung, or is it only from the throat? So the main concern here is, here in Miami, we will definitely get a CAT scan of the head and neck area, and have a surgeon stand by anesthesia to perform a possible tracheostomy. We may even actually do that before we do any study if he really appears very toxic and having trouble moving air, really making a lot of noise, so-called stridor.
Next slide.
Hello, Dr. Chan. My name is Sydney. So the presumptive lab results in the lab, a gram stain revealed few pus cells and occasional gram-negative bacilli.
Well, unfortunately, that doesn't help unless we look at it. If it's coccobacilli, it's still Haemophilus. It could be even meningococcus, depends on how cocco or how bacilli. And there's a lot of gram-negative around in the mouth, because of oral, so-called a Hay-Sack group and all that. But at least one thing, it's not a strep throat. You should be loaded with gram-positive cocci and strep. So obviously, diphtheria is still, high in the list. Wow, look at his leukocyte. It's like 30,000.
Dr. Chan, next present.
Huh?
Slide.
Okay, so here are the lab results. The hemoglobin count for the patient was 9.1 grams per deciliter. The total leukocyte count was 29,950 millimeters cubed. Neutrophil count 85%, lymphocyte 6%, monocyte 8%, and the eosinophil count was 0%.
Yeah, there's a clear indicator of very severe bacterial process, and the patient respond with a very elevated polymorphonuclear neutrophil. Yeah, a little anemic is not unexpected, in India.
Okay. So next slide, Ramson. We just discussed that, yeah.
Oh, pneumothorax. Wow.
Hi, Dr. Chen. Good afternoon. My name is Daniela. So furthermore, the patient was subjected to chest x-rays, and the x-rays revealed the presence of pneumothorax in both lung fields, and thus bilateral intercostal drains were placed on the patient.
So what is pneumothorax?
Pneumothorax is lung collapse.
Say that?
It's collapsion of the lungs.
Oh. Wow, this is very interesting. Now, that's not part of what I would assume is a throat infection with pneumothorax, both sides.
Yeah.
That means there's one possibility. If this is happening, obviously, I will be very surprised that he actually ruptured both sides of the lung. We do not know whether you actually have a cavity in the lung and then rupture. If we assume this is all related to what's going on even in the throat area, one can have, infection, severe, nasopharyngeal infection that dissect itself along the so-called prevertebral fascia all the way down to the heart, and causes bilateral empyema and mediastinitis. But pneumothorax, that's unusual. Unless he somehow aspirated and he already had a lung abscess with cavity and then it burst. That is unexpected. I do not know why he should have bilateral pneumothorax, or else this is just an anaerobic kind of a infection that go all the way to involve the lung.
Next slide.
So following the chest x-rays, the patient also received 3 classes of antibiotic treatment, which consisted of amoxicillin, clavulanic acid, amikacin, and metronidazole.
Okay. I can't argue with that. Metronidazole is very good for the anaerobe, and amoxicillin clavulanic will cover most oral agent, including most of the cause of throat infection. And amikacin is thrown in for safety in case of bad gram-negative. So it's a very powerful triple antibiotic combination.
Next slide.
Good afternoon, Dr. Chen. My name is Darius Dims. Even after admission of treatment, we still had further deterioration. We had increased difficulty breathing. He had to be an emergency tracheotomy performed, and he had to be maintained on mechanical ventilation.
Yeah, I kind of expect that he should be having tracheostomy. The kid has so much stridor. And now he even had bilateral pneumothorax. I mean, the chance for him to breathe normally is very little. And now you can control his breathing with a machine. And then you can have access. The nice about tracheostomy, around a regular endotracheal tube, but you have access to his throat, okay, the mouth. And let's say ENT need to do something surgically, or we need to drain or whatever, you can have access. So tracheostomy is definitely a nice thing to do.
But they should have done that as soon as he came in, right?
Was that?
They should have done the tracheotomy as soon as he had come in.
Well, they might have done it, they call it emergency. It's just a sequence of the slides, I presume. They might have done the ER. And the chest x-ray normally done in the ER, and the chest tube was put, everything probably done in the ER.
Okay, next slide.
Oh, wow.
Good afternoon, Dr. Chan. My name is Derek Woodard, and today I'm going to present to you the results of the microscopic examination in the aerobic culture found during the study. So as you can see to the left, that is the chocolate agar plate that was prepared in the study. This result is shown after 48 hours, where you can see gray colonies growing, and the gray colonies is approximated to be 2 to 3 millimeters in size. To the right, you'll see the figure that shows a picture of the gram stain smear that was retrieved from the back of the throat of the patient. And just to clarify the picture, the bacteria found was arranged in an angular fashion.
Okay. Well, okay, let's say, since you mentioned anaerobic, and previously you also mentioned the gram-negative bacilli, then the number one, concern here is Fusobacterium necrophorum.
Wow.
Yeah, it actually causes what we call Lemire syndrome. But normally it causes a thrombosis of the jugular vein and causing septic pulmonary emboli to the lung. And they do have severe pharyngeal process. But the unusual presentation is really the septic emboli to the lung, and can happen in young people. Actually, we see it at least once a year at Sinai these day and age. So given all that, my number one concern is, could this be Fusobacterium? They call it because you look at the gram stain, they look fusiform. They taper on both ends. You know what I mean?
So let him show you the next slide.
So this is the result of the Albert staining that occurred.
Albert stain, I'm not familiar. I did not, Dr. Kalai, we had to help me out with this.
I figured he won't be familiar, Dr. Chan. So I figured that he won't be familiar with this. So next slide, could you guys explain the next slide? So he doesn't know what is Albert staining, right? So
I don't know what Albert staining is.
yes. Okay, can you go to the next slide?
Hello, Dr. Chen. I'm Ramson Munoz.
Like terminal granule. Huh?
Yeah, President Ramson.
The results of the Albert staining revealed a green-colored bacilli with bluish-black terminal granules. With specific bacterial infections, Albert staining is done to recognize these granules. So I don't know how much information I can give
You
away.
really got me stuck here. And normally, the granules, I see a lot of spores. And this obviously concerned about Clostridium, but they are gram-positive. You know, gram-negative bacilli with granules tapering and the Albert stain that look green. I do not know. You got to teach me now. I'm love to learn this.
Okay. So given the presented information, the infection was a fossil infection of diphtheria caused by Corynebacterium diphtheriae.
Diphtheria stain like that?
A patient presented decreased oxygen saturation levels of 18%, and given the pathogenicity of the bacterium, the presence of an antitoxin is necessary to treat in time, and given that it was in India, it may not be readily available. So unfortunately, the patient died.
Stay there for a second, Ramson.
Yes.
So Dr. Chen, what do you think?
What is partial diphtheria? That's very unusual. Diphtheria is, as I remember, is Corynebacterium, right?
Yeah, Corynebacterium, correct.
But that I do not understand, you know. So like I say, these days, you know, I had to check out whether, oh yeah, you say Corynebacterium on top. I didn't even see, I was just looking it down here. Whether the Albert stain and all that, I never done the Albert stain or the hospital lab ever performed one for me. Normally should grow, you know, and yes, this is very unfortunate that the child never received, you know, the childhood, you know, the vaccinations, you know, of diphtheria. I mean, TD, you know, it's like everybody should have gotten TD. I get TD booster every 10 years. And now even add on pertussis, because I have young granddaughters now. I don't want to be the one that pass it to them.
Yes. Yeah.
Yep. So every 10 years I got TD and P.
Wow.
I hope you all got up to date. If not, you haven't got one for 10 years. You should all get up to date before you show up in the hospital.
Yes. Yes, probably should, and adults definitely. So, Dr. Chen, so this in the beginning you did predict it's a diphtheria. Then
what?
why in the beginning you did say it was?
Well, I say, but I wasn't sure that they grow anaerobically because honestly, I haven't looked at microbiology of Corynebacterium diphtherium for a long time.
Okay.
Majority of this is supposed to be gram-positive.
Yeah.
I would go gram-negative bacilli.
Yeah.
Gram-positive, in a hospital, we grow a lot of so-called diphtheriae. They look like a diphtheria, gram-positive is not. And also, it can be confusing. I should know because they claim that diphtheria on a microscope look like Chinese characters. Absolutely nonsense. I write Chinese. And they don't look like Chinese characters to me. But then you can see they are, you know, when you do it, you know, with the emphasis of a brush. But all the diphtheria we had is all contaminant, you know, these days. Corynebacterium species. So I was thrown away by gram-negative bacilli. And then I didn't know it grow anaerobically either. Does it grow anaerobically? I have no idea.
That I do not have to check that.
Those may be the reason why I was more thinking of Fusobacterium and changed my mind.
Okay, continue.
I go back and read my microbiology and diphtheria.
Yes. Ramson, you want to continue?
Yes, please. And we'd like to thank you, Dr. Chen, for allowing us to give this talk, Dr. Mathee for giving us guidance, and the FSTAR and DOT program for giving us this space and this opportunity to learn this research process.
All right. Thank you, Ramson. Stop sharing this.
All right, any other questions?
Yes, Dr. Chen, thank you. I hope this was a very exciting and educational for the students. So I wanted to tell you that these students are undergraduates.
Oh.
And they some juniors to senior level. They all are interested in going into medical school. They're part of the summer program we run in FIU. And since COVID-19, they're not physically in FIU, so they are from Florida, Louisiana, and UCF, Louisiana, and from New Orleans too, right?
Yeah, Xavier University.
Xavier University. So we have a bunch of universities outside Florida, and they have been working together as a group for 3 weeks now. So this is their 3rd week. Would you like to make some comments about the presentations, the cases, students? The floor is yours.
No, I think those cases are extremely great. I wish I knew a little bit more about the diphtheria microbiology. Now I'm going to have to go read. One thing I can tell you, if you end up at medical school in FIU, make sure you rotate medicine and infectious disease among Sinai. You will, so we can have it a hand-on, person-to-person teaching. Okay, thank you. This has been exciting. I've been so bored to death at home.